I'm Rut Patel. I work at Advanced Urology. I'm in the Sandy Springs and the Alpharetta office. I trained at Rutgers University in New Jersey. I did my residency there also. And then I went to fellowship at University of Southern California in Los Angeles for advanced robotics and oncology fellowship. I've been in Atlanta for about 3 years now. I did want to move back to the East Coast, so this was sort of a new home for me, but I love it here and would love to take care of patients around the greater Atlanta area. The talk is going to be fairly informal for whoever does join on. We can just type in questions along the way and I can answer them as we go, or at the end if they catch up a little bit later. So, the main reason I wanted to talk about this because I do have a passion for prostate cancer, and not only prostate cancer in general, but just prostate health. And the reason it's important is that it's actually one of the most common issues that men will come to see a urologist for. A lot of urinary and sexual complaints actually stem from a prostate problem, and many people don't seem to realize that. These symptoms are also slow growing in nature, and patients sort of become complacent with them, where it's actually affecting their quality of life and health without really them noticing. And some of these problems, if we don't address, they can cause long-term issues and they may not be correctable later on. And I do find that addressing these problems actually improves the patient's quality of life to the extreme satisfaction. And so seeing that turnaround is one of the actual pleasurable parts of being a urologist. So the objective of this talk is going to be fairly simple. It's mainly to understand what we do as urologists, because even as a medical student, I had no idea until I actually rotated through urology. It's also important to understand some common prostate problems, such as prostate cancer and then enlarged prostate, because again, these are common things that men will come to the urologist for. And then if we have time, we can also discuss more other basic conditions, talk about treatment options of other more common diseases. So as urologists, we are basically surgeons of the genital and urinary tract. We deal with the kidney, ureter, bladder, the prostate in men, urethra, penis, and scrotum. We work as different types of surgeons. We can work as plastic surgeons, cancer surgeons, even prosthetic surgeons. And then I specifically work as a robotic surgeon to deal with disease processes throughout the entire system. And in terms of the anatomy of the genital and urinary tract, you have what starts from the top down, the kidneys, which are basically a bean-shaped organ that help filter out toxins and also waste and medications from the blood. They produce urine, which then gets transported through the ureter, which is a tube that connects the kidney to the bladder. And the bladder is mainly meant as a storage unit, which should expand easily and then squeeze to push the urine out through the urethra or the tube that you pee through. And in men, the prostate sits around the urethra, which helps secrete fluid that nourishes and protects the sperm. So you could have, potentially a problem anywhere along this. And as urologists, we are trained to deal with that. So what exactly is the prostate? It's an organ that's needed early on in life for sexual development. But as you age, it no longer serves that function or has any relation to testosterone production. It is an organ that helps, like I said, produce nutrients that nourish the sperm and the ejaculate. But other than that, as you get older, it does not serve any other function. On average, it's about the size of a walnut, but it can continue to grow. And as it feeds on testosterone, it can grow up to the size of a softball or even larger. The reason we care about prostate health is if you look at the estimated new cases of cancers in men, the number one diagnosed cancer in men is prostate cancer. And that's about 20% of new cases. And this was about a couple of years ago where the estimates were. The other important thing is that it's also looking at the list down here, about 10% of cancer-related deaths is prostate cancer. So it's the most common cancer in American men. It's also the second leading cause of cancer, like we discussed. But specifically, 1 in 8 men will be diagnosed with prostate cancer over their lifetime, and 1 in 41 will actually die from prostate cancer. So screening is an important strategy when it comes to preventing some of these deaths. But we'll also discuss some of the pitfalls with screening that have come to surface over the past decade or so. The other thing to note is that, approximately every 20 minutes, another man dies from prostate cancer in America, at least. So what are the risk factors? We talk about age. Usually patients greater than 55 tend to be the higher risk factor for prostate cancer or for developing prostate cancer. Also, race plays a factor. African American men tend to have more aggressive cancer and tend to be diagnosed at an earlier age. The other thing that you can see is that family history, specifically people who have prostate cancer in the family, if their father has prostate cancer, they're at about a 25% increased chance of having prostate cancer. If their brother has had prostate cancer, they're at about a 33% chance of increased prostate cancer. And with new research that is being done, we're also seeing links in the family to colon, breast, or ovarian cancers, and specifically the BRCA gene is something else that has been come to play that shows that there's an increased risk of prostate cancer in people who've had that in their family. The downsides to prostate cancer is that there's no symptoms of it unless it is the late stages. So that's why it's important to screen these patients early on so that we can find a local or even locally advanced cancers, because the urinary symptoms that people experience tend to be related to an enlarged prostate and not necessarily to cancer. The reason for that is that there's really two main zones to the prostate, and the peripheral zone, or the outside of the prostate, is sort of where the cancer grows. And the inside part is where sort of the enlargement of the prostate happens, which starts blocking the channel that you pee through, and that's where the urinary symptoms occur. So it's two different disease processes, and that's why it's important that we screen these patients. And what is the screening nowadays involved? It's basically two things. One is a PSA, which is the blood test. The other thing is the rectal exam. What we do need to find is sort of the gestalt of the screening process is sort of figuring out the intervals or figuring out who to screen and at more aggressive screening intervals. And we can see that when the PSA screening was more widely implemented in the early 90s, we saw the incidence of patients coming with widespread disease drop about 50%. And since that implementation, it has stayed at a relatively low level into about 30 or 25 people per 100,000 until the late or early 2010s, when the USPSTF task force recommendation against screening came out. And we've started to see that there has recently been an uptick in numbers because the screening after that task force recommendation did actually start to drop off. So let's get into actually the evolution of that PSA screening or the prostate cancer screening algorithms. The current guidelines on the PSA screening are sort of mixed when it comes to different regulating bodies. So we have to look at which guidelines you sort of follow and which ones are available out there currently. So, we had discussed about the USPS task force guidelines in early 2012, which suggests that the risk of screening outweighed the benefit. And when they had made that recommendation against screening, that's when the guideline, or that's when the PSA testing sort of started to tail off. But those guidelines were based on trials that did not show any benefit to screening. And there were two problems with those trials. One was that patients in the non-screen group were also receiving screening outside of the trial. So that was not accounted for. The other thing that's a problem with any of these trials is that prostate cancer is a slow-growing disease, and it takes time and long-term follow-ups to see if strategies are actually working. And so most recently, they actually changed their recommendation to say that patients who are 55 to 69 should undergo a shared decision-making. And the reason for that is, as more analysis was being done of those trials, we were starting to see a benefit in screening. And the number of patients or number of men needed to screen actually started dropping with more and more follow-up. Initially, it's about 780 patients needed to be screened to prevent one cancer death. And now it's become, with more stringent analysis, that it's about 230 patients to screen in the age group of 55 to 69 to diagnose the 10 cancers. And then that's to save one prostate cancer death. So I think with this new data, we're obviously seeing more patients being screened. We're also seeing which patients need to be screened with the new risk factors and other things that we're discovering. And looking at the NCCN guidelines, this panel is also favoring beginning testing screening, but they're actually favoring it at age 45, and then repeating the screening intervals depending on the PSA test. So it's good to know, having a baseline PSA for these patients at the age of 45. If their PSA at baseline is greater than 1, then the yearly interval of screening should be much higher. And that yearly interval is probably about 1 to 2 years. Whereas if their PSA at baseline is less than 1, then screening can be sort of more spread out, and that would be about a 2 to 4 year interval. And they also consider a study in this that found that patients who are older than 75 with a PSA of less than 3 never really died from prostate cancer. So this actually sort of suggested that men over 75 should have a cutoff of, if their PSA is less than 3, no longer needing screening furthermore. And they also took into risk factors such as race and family history, whereas the USPSTF task force did not beforehand. And the reason for that is African-American men, we talked about, are at higher risk. They're at about 65% higher chance of having prostate cancer. And they're at about a 2.3 times increased risk in death from prostate cancer compared to Caucasian men. They also tend to be diagnosed about a year earlier than Caucasian men, with a two-fold risk of being diagnosed even before the age of 45. So it's, you know, quite important, I think, to get patients who are African-American with a strong family history to at least have a baseline PSA in their 40s or early 40s if possible. Men with family history of prostate cancer had about, like I said, 2.5-fold risk of developing it. And they did not see any increased likelihood of finding aggressive disease with these baseline PSA. So that is also something where genomic testing may become relevant in the future. The AUA guidelines also, you know, have the same risk factors in play to determine testing, but they reduce the age to 40 for patients who have high risk factors. Again, the greatest benefits is going to be in the patients who are 55 to 69, but that's where that shared decision making comes into play. And that's where knowing the risk factors or knowing the patients you should be aggressive on come to play. The one thing that I do think the AUA makes a good recommendation about is that the threshold for biopsy in patients who are older than 70 should be at 10. So if their PSA is less than 10 and the patient's older than 70, you can avoid biopsy even if it's a PSA of 5 or 6, depending on the discussion that you have with the patient. And the ACS guidelines sort of mirrors some of the ones that we mentioned above. So basically, you know, in conclusion, when it comes to screening, in terms of the high-risk group, as we discussed, the African-American men, the strong family history, we should discuss screening at least age 40 to 45. The average risk group, we can delay it. And then the yearly intervals can be every 1 to 2 years, just depending on what the baseline PSA is. The main thing is, you know, having that shared decision making, and that should be initiated at the earlier stages in the man's health, and to stop the PSA screening if their life expectancy is less than 10 years old, and then to also consider stopping it if their PSA is less than 3, or changing the trigger for biopsy if your PSA is less than 10. No matter what prostate cancer you have, it's important to know that not all the cancers are the same in terms of prostate cancer. If you're diagnosed, it's important to risk stratify the patients, because not all the cancers have to be treated. Over the last decade, probably active surveillance has been a radical shift in the treatment strategy. And I think some of the argument that the task force had in the early 2010s about overtreatment of prostate cancer is sort of alleviated by this. So patients who have a very low risk as determined by their Gleason score or their biopsy characteristics can be considered on active surveillance, especially if they're young and healthy and they want to avoid the morbidities of treatments that may be available. Whereas the intermediate risk patients and the high risk patients should consider treatment with either surgery or radiation, which we'll discuss in a little bit. So active surveillance, you know, it's basically a treatment strategy to avoid the risk of surgery. And the reason why active surveillance has gained favor and has shown long-term effectiveness is the fact that patients who have low risk cancers, so that's Gleason 6 disease, PSA is less than 10, sometimes even biopsy characteristics that they look at, such as having less than 50% of core involvement or having a low number of cores involved with prostate cancer. If that criteria is met, we have seen that about 50% of those patients will never develop any progression of their cancer, or will never require a need for intervention of their cancer. So in 50% of patients, we can avoid the morbidity of the treatment. Whereas in the other 50%, they have time to, you know, sort of progress where we can capture them and intervene as needed. And so usually the surveillance protocols do differ depending on which locations you go to in terms of their academic affiliation, but usually it consists of regular PSA checks at least every 6 months or so, repeating a biopsy within 1 year, which is called the confirmatory biopsy, to make sure that, you know, again, since the biopsy is a random sampling of the prostate and you're trying to hit the cancers that may be there, you may have missed the cancer with the first biopsy. With the second biopsy, you can confirm that, yes, it is a Gleason 6 cancer. There's not much more involvement than what you had seen before. And then again, annual prostate exams, sometimes you may add MRIs or other testing available. But all these things are sort of to see if there's any progression of cancer in order to figure out if there's an intervention that needs to happen and when it needs to happen. The downsides of an active surveillance protocol is really patient dependent. Some patients cannot handle the diagnosis of cancer, and they're the kind of patients who would want treatment regardless of what the type of cancer it is. But there's also a small chance, about 1 to 2% chance, that they could develop metastases or locally advanced prostate cancer prior to their other steps in terms of their active surveillance protocol. So it's very rare, but we could miss a chance for a cure. So that's a discussion that we would have to have with patients. But most of the time, if they have a very low risk disease, active surveillance is a very good option for them. And I do have a fair amount of patients on active surveillance. It's just something that they would have to be comfortable getting biopsies and MRIs every so often to continue to monitor their disease. So in terms of treatment, aside from the active surveillance, the other major step in the treatment of prostate cancer was the introduction of robotics since the early 2000s. And currently, it's the surgery that is the gold standard for prostate removal. We can actually do them in the same day now. We have one in our surgery center, and we can do same-day prostatectomies. We've done probably over 100 or so of them over the past year. All patients have been going home. The risk of outcomes or surgical comorbidity is very low. They can be back to work within 2 weeks sometimes. There's less blood loss with robotics. There's less pain. There's smaller incisions, as you can see. Each incision is about the size between, like the size of your fingertip almost. The surgery is about 3 hours or so. And if they're in the hospital, they may stay overnight. Otherwise, they may go home the same day. Really, the main issue is that they have a catheter for a week. And then they have what's known as quality of life issues. So after surgery, they tend to have urinary leakage and they tend to have softer erections. The reason for that is there's nerves that run alongside the prostate that have to be spared. And depending on their extent of disease, some of those nerves may have to be sacrificed. But no matter what you do, there is some neuroplaxia or sleeping of those nerves, which requires some time to recover. But with the robotics platform, you can actually see those nerves. You can spare the nerves at a greater efficiency and efficacy. And most of my patients, within about a month or so, they're fully continent. They're maybe needing a pad just to capture a few drops of leakage. And in terms of erection function, it's usually within 3 to 6 months that they're had strong enough erections for penetration or for intercourse. The other option that's available to patients with prostate cancer is radiation. Now, there's plenty of different ways to deliver radiation, but at the end of the day, it's the same sort of beast. It is less invasive than surgery, so patients can, continue living their normal life without having any morbidity of the surgery. But it does require many visits in order to receive the therapy. The other downside to radiation is that you have to combine it with androgen or hormone therapy to have the efficacy that you have with surgery. And also, a recent article or a study has come out that in high-risk patients, which are patients with Gleason score of 8 or PSA over 20, that actually surgery has a better long-term survival than radiation does. The other downside to radiation is that if the cancer comes back, surgery is very difficult on that area because of the radiation. So you sort of are left with secondary or subpar treatments to help control your cancer. So it's really best suited for patients who are older or those who are not good surgical candidates. The one downside that they don't mention when you get counsel for for radiation is that because the radiation is meant to go through the prostate, it still has to go through the bladder, and sometimes it gets deposited on the rectum. There's about a 3 to 5% chance of developing a second cancer of the bladder or a second cancer of the rectum. And so, that's something to consider for patients down the line. And the other major difference between the two is that with radiation, you don't really get any more information because the biopsy is the only thing as far as prostate tissue that you have. With the prostate removal, you take out the prostate, you take out the lymph nodes, so you get a lot more information, you get a lot more easier way of monitoring the cancer, and you can really understand where patients fall into in terms of their recurrence going forward. So to shift gears a little bit, we can talk about other problems of the prostate besides just cancer, which are the benign problems, which include prostate enlargement. Now, most of the times this causes urinary problems. Usually it starts with a decreased flow rate, increased nighttime peeing, nighttime voids, increased frequency, urgency, weak stream, and also post or dribbling at the end of urination. Usually a common scenario in the office or clinic is that a 60-year-old gentleman or some 60-something-year-old gentleman coming with difficulty peeing. They have had many months where they've been waking up every 1 to 2 hours to pee, And when you talk to them, they consider it a normal thing or a normal sign of aging. But if it were to happen overnight or over the course of a week, nobody would assume that was normal. So that's the downside of these sort of enlarged prostate. It's such an insidious quality of life change that patients don't seem to realize what's been happening to them. And a lot of times they're avoiding small amounts every few hours or even every few minutes. They have to strain to empty. They have a lot of other medical problems which could confound the situation, such as diabetes or hypertension. And so most of the time, the causes of these problems is really a bladder outlet obstruction from an enlarged prostate. But you could have a urethral stricture if they've had previous instrumentation. You could have prostate cancer, as we discussed before, or you could have just poor bladder function from a diabetes or from a nerve injury or neuromuscular disease, or an overactive bladder if the patient has suffered from a continued blockage from the prostate for a long period of time. And if you were to get some imaging, you may notice an enlarged prostate, you may notice the bladder full of urine, but you're also going to start to see swelling of the kidneys. And with the large bladder and that swelling, you could start to see decreased function over time because the kidneys are not able to empty the urine out completely. You could start to have electrolyte abnormalities. You may even get blood in the urine. And, some of these things become impossible to reverse. And so with urinary retention, with an enlarged prostate, it becomes a challenge to intervene at the right time. And the reason it enlarges over time is because of testosterone, as we discussed before. The prostate feeds on testosterone, and so it enlarges and narrows the urethra, and it makes it difficult for patients to void. We talked about those symptoms before, but really those symptoms are late stages, or when the enlargement has been sort of going without being kept at bay. And what you tend to see when you look inside the bladder is that the bladder muscle gets thicker and thicker to create pressure to force the urine through. And then over time, it can become quite thick and full of outpouchings or diverticula that are not reversible. The bladder really should be like a balloon that can fill easily with urine and without pressure. When you have continued blockage, it becomes more like a rubber ball, and it takes a large amount of pressure to fill, and it cannot fill to the same volumes as before. So patients become sort of having an overactive bladder type of picture, which they have a lot of urgency and frequency. So even when you fix the outlet problem or when you fix the prostate, their changes to the bladder may not be reversed, and they may be overactive bladder patients at that point. So what are some tests for the enlarged prostate? I mean, we've already just discussed the PSA. This is mainly to just rule out prostate cancer because, again, we have to screen for that. But then the other things that are important for us to know is what is their post-void residuals? Are they able to empty their bladder completely? Because if not, that just sets them up for bladder stones, kidney problems, urine infections, you name it. The other thing we want to see is urodynamics. Basically, this is like an EKG of the bladder. We see how the bladder muscle is working. Is it squeezing on its own? Is it squeezing at high pressures? Is it able to empty completely? Is the urethra working normally? How do we what do we need to attack? Basically, do we need to fix the bladder? Do we need to fix the prostate? The whole system, if you think about it, should be like a funnel. The treatment of an enlarged prostate is easy to think if you think of it like that. So you can either make the mouth of the funnel wider to allow more urine to sit here and empty, or you can actually make the channel wider so that more urine can flow through that area and you can improve the emptying. The treatment options for an enlarged prostate are run the gamut at this point. I mean, with BPH, there's so many new technologies, so many new treatments, it sort of sometimes may become overwhelming. But the main things you have to know is medication or procedure. So medications, the two main options available for patients is really alpha blockers or the dihydrotestosterone blocker, which is the finasteride. The finasteride is meant to shrink the prostate and tends to be more effective in patients who are prostate sizes over 50 or so. But again, the shrinkage works really maximum maybe 30 to 40%, and that's over years that can happen. The alpha blocker, the Flomax, or even like the rapid flow or other things, they're meant to basically do the opening of the mouth or widen the mouth of the funnel, which allows more urine to sit at the bladder neck so that it can be emptied throughout. The outpatient treatment options where the TURP or the UroLift or any of the other minimally invasive procedures, they're meant to make the channel bigger so that the flow of urine can be faster through that area so that you can empty the bladder better. They're all meant to do the same thing, where it's just open the channels. It's just done a different way. So with the transurethral resection, you're sort of coring out the or interior part of the prostate. And again, because you're doing that, there's a good amount of bleeding. Patients usually need a catheter for a few days. It can be done as an outpatient in the surgery center. Sometimes if the prostate is too big, it probably needs to be done in the hospital because of the bleeding. The UroLift is a more minimally invasive option, which works really well for patients who have small prostates, and also for patients who are concerned about some of the sexual side effects that can be present with the other treatment. So with the UroLift, because there's no cutting, there's no current, there's no chance of any erection or softer erections. And there's also no chance of any damage to the urethral sphincter, so no chance of leakage of urine after a procedure like this. And what it involves is just tacking a suture through the prostate on a pre-tensioned device so that it creates this nice wide opening and it compresses the tissue. Again, there's no catheter that's needed for this. The whole process probably takes about 30 minutes, and patients do fairly well as long as their prostate anatomy is meant for this. Now, when your prostate becomes severely enlarged, anything over 100 grams or so, you're looking at probably the two main options, which is aquablation and a robotic simple prostatectomy. The aquablation uses an ultrasound and a water jet, just think of like a power washer, to clear a channel through the prostate. The downside to the aquablation is it really only clears about 120-degree channel through the prostate. So over time, that area can still regrow and you can still have the same problems that you may have had before. With the robotic simple prostatectomy, you're doing the same thing. You're coring out the prostate, but you're coming in between these two planes and you're coring it out 360 degrees. And so you take a lot more tissue and you create a large cavity in the area of the prostate without damaging the nerves, without damaging any of the external part of the prostate. So you don't have the urinary leakage or sexual dysfunction that you would with some of the other procedures, but you take away a large proportion of their tissue, which has been causing the problem. And with this, really the shelf life of this procedure is probably about 20, 25 years. So, most people, they get this procedure in their 60s and 70s, they're going to be peeing like they were in their 30s, and they wouldn't have any further treatment ever needed for their prostate. And they also wouldn't need to be on any medications or anything else for their prostate. And that's kind of important because as their population ages, we've sort of seen new studies come out that show maybe a possible link of dementia with the alpha blockers. Some studies say yes, some studies say no. We still don't know what the jury is saying for that one, but it's important if we can avoid patients to be on these medications. It's nice to be able to avoid that. And then the other main thing that people tend to come to see a urologist for in terms of talking about their prostate is what's known as chronic pelvic pain syndrome or chronic prostatitis. You can have 4 different types of prostatitis. Really, it's chronic bacterial, acute bacterial, or even non-bacterial prostatitis. I think chronic pelvic pain syndrome or chronic prostatitis is sort of the most common type. Pain from it can last for weeks to months to years. Patients usually come after they've had it for many years. They've tried ultrasounds or other things, and it's not been effective. It's not an infection, but symptoms mimic like infections, or symptoms mimic those of patients that have had chronic bacterial prostatitis. Usually, if you do any urine test or semen test, they're all negative. It stems from an inflammation of the prostate with nerves that supply the area. The pain could also be from muscles of the pelvic musculature. And some of the symptoms are either trouble passing urine, pain in the bladder, testis, penis, any in the perineum, could be even in the anus. They have trouble or pain with ejaculation. And a lot of the mainstay in terms of treatment for this is, pelvic floor therapy. So it's important for them to see a pelvic floor physical therapist to learn relaxation exercises, to learn even point muscle tenderness relaxation. Sometimes having pelvic floor suppositories with Valium or baclofen tends to be helpful in these patients. Sometimes even doing a nerve block or Botox injections to the pelvic floor, which can help relieve the sort of fasciculations or the tenderness of the pelvic musculature. Some of the other prostatitis we mentioned, the chronic bacterial prostatitis usually occurs from a chronic infection that requires multiple weeks of antibiotics. Doing a semen culture tends to help diagnosis, as that will grow likely some bacteria in the semen. But that can also be a mixed bag. So sometimes just steroid use or sometimes just long-term antibiotics is probably what's needed for this. Acute bacterial prostatitis is usually pretty easy to diagnose. Patients tend to have fevers. When you do a prostate exam, it tends to feel boggy and like a very soft prostate. Sometimes fluctuance is noted. They usually require IV antibiotics. Sometimes may even need to have a procedure done to unroof the abscess or unroof that area. But a lot of times, patients coming to the office in terms of testicular pain or pelvic pain is really from that chronic pelvic pain syndrome that we talked about. And the main, like we said, the main diagnosis for these things, the rectal exam, the urine semen test, sometimes an ultrasound, like a transrectal ultrasound, but lastly, sometimes you may even need to do a cystoscopy to rule out some other urinary issues that may cause a similar thing, if there's an anatomical issue present or not. The other important thing to know is sort of elucidate some risk factors for patients, which could have, or who they could be at a risk for bacterial infection, like a bladder infection, or if they had a catheter, or if they have had STD or previous unprotected encounters, or even if they've had anatomical issues in the past in terms of urinary tract. The frustrating part with dealing with pelvic pain syndrome is that it can take a lot of tests to figure out exactly what's going on. And sometimes even these tests may not give us the answers that they want, because a lot of times it's just not related only to a muscular problem. And so the treatment, like we had discussed before, antibiotics, lifestyle changes are also important, such as weight loss, diet changes, learning to relax the muscles or exercises for pelvic floor. Also avoiding certain triggers like spicy or acidic foods, caffeinated drinks, alcoholic drinks, and stopping things that make the pain worse, like bicycle riding, or sometimes heavy lifting can do the same thing. Again, pelvic floor physical therapy is a huge mainstay in the terms of treatment for these people. And the suppositories, like we discussed before, sometimes acupuncture even works. And then if the patient is sort of an older male, or if they have an enlarged prostate or other urinary problems, sometimes fixing that problem actually makes their pelvic pain and other issues go away. And I think we can probably stop here. This is my last slide before the end. So any questions at all about stuff that we discussed? Everything else is sort of just, talking briefly about basic things or basic conditions to send to us about also.
I think that was great information, Dr. Patel. I don't see any questions, but we'll give it a second to see if we get any come in. Also, if you want to just talk about some of the services or where you are location-wise, we do have surgery centers, so you may want to bring that up too.
Yeah. I mean, in terms of our group, we're sort of all around Atlanta. We have surgery centers all around Atlanta, so that patients really are within 20, 30 minutes away from where they're located at. I myself go to the Sandy Springs area, which is affiliated real near the Northside Hospital, and also in the Alpharetta, which is right across Western North Fulton. And then in terms of the surgery centers, our robot, because we can do same-day prostatectomies at our Alpharetta location, where I am usually doing a Monday prostate surgery there. So patients who are extremely interested in a same-day and quick turnaround is a good way to, have them see us in the Alpharetta location, because we can offer that to them. I see a few questions in the chat. So, yeah, is it true that Mediterranean diet may decrease risk of prostate cancer? So there's been no, sort of hard-hitting evidence that proves that, but we have seen correlation that a Mediterranean diet can reduce the risk of prostate cancer. Also, a vegan diet, or in terms of activity level, actually exercise has been shown to have some correlation to reducing the risk of prostate cancer. Another study that which patients may find useful, is that actually the number of ejaculations per month or sexual activity had been shown potentially linking to reducing prostate cancer. And I think based on that study, the number of ejaculations per month they had quoted was about 21. The role of using free PSA. Yeah, free PSA is a different, it's basically a PSA that's not bound to protein in the blood, and that ideally has been used for patients with a PSA of 4 to 10. And when the percentage of that is less than 15%, as when you sort of get worried about increased risk of prostate cancer. I think overall, the free PSA probably has been replaced by the 4K score, which looks at 4 different types of PSA, and you get a more appreciative risk score in terms of their development of prostate cancer or their chance of finding prostate cancer on a biopsy. And then some of the other testings that I didn't get into or go over are the genomic testings, like the 4K score I just mentioned here, but there's also Oncotype DX, which are testings that you can do on actual specimen, either from the biopsy or from the radical prostatectomy, which is looking at genes specifically in the cancer to identify risk factors for their chance of recurrence after a prostatectomy.
I think those are great questions. If anyone would like to ask any further questions or get in touch with our office, our phone number is there. You can also reach out to myself, and I'll put my information in the chat for an appointment. I think we have one more that came into the chat, Dr. Patel.
Yeah, the question was, what age should I start getting my prostate checked if there's a history of cancer? It sort of depends on what age the individual was diagnosed with that history of cancer. But at the very minimum, I would say at least at 45 or 50 would be, you should have that discussion at starting at 45 about getting screened for prostate cancer.
Awesome. So we again want to thank everyone for joining us tonight. And Dr. Patel, someone in the chat said, thank you for the information. So I think this is valuable information for us to always speak about, but there's someone out there who needs our information further or want to know more information. You can always reach out to our office or myself, and we're happy to assist in any way. We do accept same-day appointments, but our purpose here is to make sure we're educating the community and our patients and physicians, and want to keep this an open conversation. Prostate cancer is very important, and we appreciate your time. Dr. Patel, if you'd like to say anything further. If not,
yeah, no, I just want to thank everyone for joining. I know it's late in the day and it's getting close to the holiday time. So, but yeah, I hope everyone got something out of the talk, and be happy to discuss further if anyone has any questions.
Awesome. Well, thank you again, everyone, for your participation. We can end there.